Good afternoon and good morning, everyone, and thank you for joining the webinar, Geomedical Contracting Best Practices for Supporting Stepping Up Goals. We'll start this webinar in a few minutes. Good afternoon and good morning, everyone, and thank you for joining us for the webinar, Geomedical Contracting Best Practices for Supporting Stepping Up Goals. My name is Mark Stovall, and I'm a project manager at the Justice Center, and I will be moderating today's webinar. To give you an overview of the webinar today, I'll start by introducing the speakers. Things over to my colleague, Risa Hanneberg, who will give a quick overview of Stepping Up and also discuss how geomedical contracting ties in with county stepping up goals and activities. Then we'll hear presentations from Jim Martin at the National Commission on Correctional Healthcare, and we'll also hear from teams at the Franklin County Sheriff's Office in Ohio and the San Luis Obispo County Sheriff's Office in California. Right after their presentations, Carrie Hill from the Massachusetts Sheriff's Association will moderate a discussion among the panelists. Then we'll hear some brief remarks from Reggie Herder at Policy Research Associates about an exciting project they're working on that addresses geomedical contracting. And then we'll take some questions from all of you listening in today. For some technical notes, we encourage you to enter your questions into the Q&A box on your screen. We'll try to answer the technical questions as we go, and then turn to the content-related questions during the Q&A. And I want to note that we are recording this webinar, and a recording should be available on the Justice Center's website by early next week. We're excited to have 10 panelists with us on the webinar today. We have Sheriff Dallas Baldwin from the Franklin County Sheriff's Office in Ohio, Risa Hanneberg, Deputy Division Director, Behavioral Health, the Council of State Governments Justice Center, Carrie Hill, Executive Director of the Massachusetts Sheriff's Association and Chief Jail Advisor for the National Sheriff's Association, Reggie Herder, Senior Project Associate from Policy Research Associates, Jim Martin, Vice President for Program Development at the National Commission on Correctional Healthcare, Sheriff Ian Parkinson, San Luis Obispo County Sheriff's Office, California, Mark Stern, Affiliate Assistant Professor at the School of Public Health, University of Washington, and consultant in correctional healthcare, Chief Deputy Jeffrey Stobart, Franklin County Sheriff's Office, Ohio, Captain Carl Trowbridge, Franklin County Sheriff's Office, Ohio, Jessica Yates, Business Analyst, San Luis Obispo County Sheriff's Office, California. And a big thank you to all of our panelists for joining today. So now I'm going to turn things over to Risa for a stepping up overview and a brief discussion of the intersection of geomedical contracting and stepping up goals.
Thanks, Mark. Go ahead and go to the next slide. So first of all, Happy New Year to everyone. Thank you for joining us today, our first webinar for the year for Stepping Up. We've actually been really talking about holding this webinar and this topic for really quite some time. And I'm just really excited to be with you all today. Just a few quick reminders, if this is by chance your first Stepping Up event. Stepping Up is a national initiative to reduce the number of people with mental illnesses and co-occurring substance use disorders in jails and across the justice system. The Justice Center, along with our partners, the National Association of Counties and the American Psychiatric Association Foundation, are the three key partners for this initiative. Next slide. And just, quick review here, Stepping Up, 6 years and counting. It's really hard to believe it'll actually be 7 years this coming spring. We are now at, actually our slides need to be updated because we actually hit the 550 mark, 550 sites, jurisdictions across the country that have passed resolutions to participate in the Stepping Up initiative. And we feel we cover approximately 48% of the population of the country. We're working with over 2 million individuals booked into jails every year with a serious mental illness. Again, an update, we're up to 34 sites across the country that we are now showing as innovator status counties. Both of our guest counties with us today, Franklin, Ohio, and San Luis Obispo, California, are Stepping Up innovator sites. And we have 5 states that have launched statewide Stepping Up initiatives. So really pleased to see the work growing in that direction as well. Next slide. So just connecting some dots here between the work of Stepping Up and the intersection with jail medical contracting. Certainly not something that maybe everybody wants to get into the weeds about, but it's really extremely important, and certainly something that we've found as we do the work of Stepping Up across jurisdictions, that it can immediately come into play in terms of how successful you might be able to be in just implementing some of those key fundamental processes and the work of Stepping Up. So for example, one of the first things that Stepping Up will ask a site to do is to screen every individual who comes into your jail for a serious mental illness using a validated screening tool for that. And for those who screen positive, that there is a process in place for that follow-up clinical assessment. So just getting across, whether it's your jail personnel or if it's your medical provider that would be completing that screening, how important it is that it's a validated tool, one that is going to be giving you the results that should be, hopefully, the false positive rates pretty low with these tools and pointing you into the right direction in terms of who in your jail most likely has a serious mental illness and who needs that further assessment. We see that doing this work is important for internal jail management, all the decisions around classification, who needs maybe to be in a special pod, who needs special services, while they're being held in the facility, as well as starting pre-release planning and knowing what connections to care are going to be needed for those individuals. And then there comes data. And if you're familiar in working with Stepping Up, you know that we're extremely, extremely intensive when it comes to data and how important it is. So I know that both of our sites are going to address for us today the whole scenario of the data, who owns the data, who can get to the data, simple information like being able to flag individuals in the jail management system and being able to track those individuals and along those measures that Stepping Up asks that you complete. And then pre-release and working with that important connection to care and making sure that services are continued upon discharge into the individual being released to community. I am going to turn it over to Mr. Martin now, who is going to speak to us about his experience with the contracting process. Thank you.
Thank you, Reese. And it's always a pleasure to join Stepping Up and the Justice Center and initiatives like this. Before joining the National Commission on Correctional Healthcare, I came from a law enforcement background and ran a jail for the last 9 years. And just when Stepping Up was taking off, it was good to see that the problems that we were seeing in a facility were being addressed, not just in the facility, but also in conjunction with our community partners. So I know we're going to hear a lot from our sheriffs on this webinar, so I'll stop there. But if we'll go to the next slide, we'll show why is it important that NCCHC standards or a standard for a delivery system is important. And it's because our standards do represent, the requirements for a good, efficient, effective healthcare system, right? And it's very important that as you are considering, contracts with a correctional healthcare vendor, that you're looking, are you dependent on them to abide by those standards and run your system according to these constitutional requirements. The standards were born out of a federal court case, a Supreme Court decision on Estelle v. Gamble that mandated that our sheriffs and our jails provide, care that is equal to what they're getting out in the community. And many of our jails across the country are providing, a higher level of care than you would see in the community, and that's important because the treatment being given in these facilities for these the incarcerated population is so important that it's nationally accepted to the clinical guidelines, that they are following the guidelines of what our medical professions would expect them to. And why is it important with NCCHC standards? In our next slide, we'll talk about some of the relevant sections. So if we'll go to that slide for me. Of course, all of our sections are important, but for the purpose of this topic with medical contracting, I wanted to point out three that I believe stand out. We're talking about screening and an access to care found in Section A. We're talking about patient care and treatment. We're talking about the special needs and services. In our governance and administration section, standards in the section, specifically address the establishment of the healthcare system that ensures access to the incarcerated population. It includes professional administration and all aspects of healthcare. It talks about the monitoring, the data that Risa talked about, and the quality improvement policies that effectively, are important to the process of your healthcare issues. When we look at patient care and treatment in Section E, the standards in this section make sure that the delivery of the healthcare from arrival from discharge, and let me say that again, it's the healthcare from the arrival to the discharge and through the discharge for healthcare issues. As administrators in our facilities, you should know what's going on in your jail, in your population, and identifying the high risk areas and how you can help leave them better than we found them. And then finally, the special needs and services. We know that the jails across the country are dealing with a special population that aren't getting the care that they need, and we're providing that to them. So these standards in the section address the patients with those special healthcare needs. It establishes compliance and requirements that are specific to the healthcare issue. And that's where that ties into this contracting. If we go to the next slide, the relevant standards when you're thinking about your medical contracting are the ones that you see on this screen. We talked about the access tier. That's the roots of what our standards are, and it should be the root of what your healthcare delivery system is, making sure that the incarcerated population has access to the care. And when we talk about screening and assessment, there's a big difference. A screening can maybe be a one-time event, just looking to see what the needs of that population might have, and then going into the assessment and having one-on-ones, doing a total head-to-toe checkup, looking at their mental health status. What are some of the things that they're bringing in with them to your facility? And it's just as important for the mental health screening and evaluation as the healthcare assessment. And then finally, discharge planning. I think this is where we have such a good connection with the stepping up. What's going to happen with this person as they leave a facility and go into our community? Are they being connected with the care that they need to seek? Are they leaving a facility with a proper amount of medications? Are they getting hooked up with services in the communities that they're returning to? When we truly want to start seeing an effect of recidivism in our facilities, it's making sure that we send them out better than we found them and using these standards to provide that care that they need. And then finally, the next slide will talk about things that you might want to consider in your RFP and contract, things that we have seen at the National Commission that are important to healthcare delivery systems is the ownership of the information. If you are transitioning from a county-based healthcare system to a regional healthcare vendor or changing vendors, making sure that you as the facility, have ownership of the medical history and the behavioral health history of the population is key to make sure you put in those contracts. There's nothing worse than to come in and see that all the files that you've been building up on your incarcerated population for their behavioral and healthcare needs is now gone, and you bring someone in coming from scratch. So make sure there is a incarcerated population in your facilities, and the sheriffs own that information. And then more and more, we're starting to see considerations for monitoring, making sure that not just that the contracts being adhered to, but you're seeing quality improvement through your system from an unbiased third-party observer. And those are things that we're seeing more and more in an RFP, and we're seeing more in a contract or facilities, to have that partner working for them to identify potential red flags in certain areas. And that closely ties into transitional leadership. If you're switching from one system to another, having a team in place that can help answer some of these questions, that might be able to smooth the process and making sure that nothing's being missed, specifically the care of the incarcerated that are in your facilities. A lot of times we're starting to see penalties or incentives based in the contracts for performance metrics. And that's just to make sure that both teams, and truly is a team effort, are working together to make sure that the care is being delivered, that they're having the support from the administrations. Even more importantly now, during these challenging times that we've been experiencing, it's important for your healthcare and your corrections to work together. And finally is, the thought of, the compliance. So many times I talk to sheriffs who have said, yes, that they are looking at an outside accrediting body to help hold facilities, run their care based on the accreditation and based on measurements and compliance. And then I'll find out that it's been 3 or 4 years into the contract and they haven't gotten there yet. So if you're putting that into your contract, make sure you have someone monitoring for that compliance, and making sure that, again, it's a partnership between the facility and the healthcare vendor. It is so important as we're addressing these special needs of these special populations in tough times, and being able to partner with Stepping Up and have these initiatives and have these fine facilities that are with you here today, talking about their stories and what they've been able to do to continue to be leaders in our country and leaders in this field, is really special. And again, on behalf of all of us at the National Commission, we just appreciate the opportunity to be a part of it, and we look forward to working with you all in the future. And I think now that I'm going to turn it over to our next speaker to introduce our sheriffs.
Well, good afternoon, everyone. It's really a privilege to be with you. And for all of you who I haven't seen for a long time, hello. I definitely want to thank CSG for this important conversation. So what I'd like to do now is introduce you to Sheriff Dallas Baldwin from Franklin County, Ohio. Many of you have heard about a lot of the innovative and wonderful things that the sheriff is doing in Franklin County. And part of that is the building of a new jail. So with that, Sheriff, I'd love to turn it over to you to introduce the chief and captain, and to hear more about some of the challenges you've had and or some of the recommendations and key takeaways when it comes to medical contracting.
Thank you, Carrie, and good afternoon to everybody, and or good morning, depending where you're at. We're in Columbus, Ohio, and I might say I heard some conversation earlier about the weather in California. We're under a snow emergency. We just lifted today, so any perspective. Stepping up and medical contracting, very, very important issues. I began my police career 44 years ago this year, and worked in a jail where we might have had a nurse, maybe, and that was it. No consideration really to the inmates or care or anything. So it's really refreshing to hear this conversation and to see how things have progressed in Stepping Up. And as Jim Martin was talking, it really caught my attention a few minutes ago, talking about that relationship between the medical care provider and make sure that they're doing what they should do, and how that's affecting the inmates and the staff. When I became sheriff 5 years ago, we had a new medical contractor came in, and we thought we had addressed all the Stepping Up issues or Stepping Up initiative issues under the medical issues, addiction, mental health. And almost immediately we saw that there was a spike in suicides and suicide attempts. I mean, very dramatic. And as Jim mentioned, we went to a third party that came in and actually did a study of our mental health response, our medical response, and saw that even though we had addressed a lot of issues under the medical contract, we didn't really set the training up for our own staff and a medical provider to work well together. And that created basically a wall and no communication taking place. That can have devastating effects. So my recommendation would be, as you go through a medical contract, the RFP, take into consideration training is very, very important for your staff and their staff to really know the boundaries and to know what to expect. Sometimes simple definitions can make the difference in life and death. We brought in a third party who reviewed both sides, set up training, was well received by both sides, and had dramatic effects. It really helped out a great deal. We're farther down the road now. We have just undergone a new contract with a new provider, and I think Chief Stobart and I have talked about repeating that same process of bringing in the same company to provide training again. But I think it's just important for success to set that stage so that everybody can achieve the goals down the road. You know, we've never, in my career, we never had the addiction, the mental health, now the COVID, and all those issues that we have to address in the jail. But like I said, they're very important, and taking those initial steps can make all the difference. And Carrie, I don't know if you want me to introduce Chief Stobart or go on to the next sheriff.
No, please introduce Chief Stobart.
It's my pleasure to introduce Jeff Stobart. Many of you know him. When I came in as sheriff, he was the chief of corrections. Transferred in for a while to help build the new jail that will soon open, hopefully. And in the meantime, Jeff has resumed his old job. He is now chief of corrections. He currently has 3 jails to be in charge of. Hopefully that will end up in one large jail. But Jeff, go ahead.
Well, thank you, everybody. Thank you to CSG for having us. Obviously, the National Sheriff's Association and NCCHC, who have, quite frankly, been our partners in this thing from the beginning. To understand a little bit about where Franklin County is today, you have to kind of understand where we were. We have probably, in my 32-year career at this point, had every amalgamation of medical care within our jail that's probably possible. We had contracted it all out a long time ago. We had contracted it all out to Ohio State University. We had brought it all back in-house, and we're doing it all ourselves, in-house, run by the county. When I took over the first time as chief of corrections, that's where we were. That was a very difficult time for us, quite frankly. We had separate contracts for our doctors, separate contracts for our dentists, separate contracts for the mental health folks. We had a separate nursing contract, but all of those folks were actually sheriff's office employees. And basically, I spent all my time as a jail administrator because there were so many different specialty contracts attached to the medical and mental health services within a jail. I was spending all my time as a jail administrator negotiating contracts instead of actually being a jail administrator. That's when I was able to convince the sheriff to allow us to go out to RFP for a kind of a one-stop shop medical provider, which was also the recommendations at the time as a pilot county for the Stepping Up initiative, to kind of bring that consistency to our office, and we did that. We learned a great deal from our first kind of foray into that medical RFP, and like the sheriff said, we're now entering into our second one. And one of the things that I was asked to do today was talk a little bit about some of the unique things here in Franklin County that we do. We have, obviously, we're a major county jail. Franklin County's population is, I think, pushing 1.4 million now. We have a large county jail. Pre-COVID, our numbers, our average daily population was probably around 2150. With a bunch of criminal justice reform that's happened here in Franklin County, coupled with COVID, our average daily populations dropped down into the 1600s, which is really a good thing for us currently. That being said, when it came to pushing out this second current RFP, we had kind of a unique situation in that we have 2 very old, very antiquated linear jails currently, but are in the process of, quite frankly, building what we believe to be a state-of-the-art facility that really focused heavily on the mental health issues of the folks that are cycling through the doors of the jail, the medical issues of the folks that are cycling through the doors of our jail, as well as those folks that we're having to deal with, which we have been in Franklin County for some time. Franklin County is kind of ground zero of the opioid epidemic. So to the rest of you, you're welcome for that. But the medically managed withdrawal that's occurring in our jails. So we have designed a facility, the physical plant of the facility, to support all of those endeavors. And those are, again, things and recommendations that came out of our original Stepping Up initiative plan. The decision to build a new jail was, quite frankly, because we were not housing folks who were mentally ill appropriately in our facilities. And because of our physical plant, we were unable to do that. That made it interesting for us processing this RFP for the new medical services, because we not only had to ask the respondents to the RFP to provide us with staffing plans for our 2 current facilities, but our commissioners were very interested, obviously as our funding source, to see what the costs of operating a very well-run medical and mental health unit within our jail was going to cost them moving into our new facility. So we basically had to ask them for staffing plans for our 2 current linear facilities, as well as a staffing plan for what is going to be our new facility. The other thing that's kind of unique about Franklin County is we have, working for the sheriff's office, we actually have a full-time administrative contract monitor and a full-time clinical contract monitor. And that is something that is incredibly helpful when it comes to processing, obviously, this type of stuff, CQIs, things of that nature, and we'll get into some of that here in a little bit. But we had a very robust, diverse team that actually spent a great deal of time and effort putting together our medical RFP. We had, obviously, Captain Trowbridge, who's on the call, was heavily involved from the security side. We had both our administrative contract monitor and our clinical contract monitor that were heavily involved in putting together the RFP, as well as our risk manager from the legal side of the house. Some of the things, obviously, that we put in that I don't know that are unique, but we certainly wanted to address all of the Stepping Up initiative issues as part of moving to the new jail and as part of staffing what is going to be, what we think, a pretty high-speed facility. 24/7 mental health care was something that we wanted to make sure we had, and not just one person. It's a pretty robust staffing plan that we have that includes having mental health clinicians embedded directly with security staff in both our acute and non-acute mental health housing units. So we have designed a facility and we have created staff posts, for lack of a better term, that are designed and large enough to support both security and mental health staff to be embedded in those places. And obviously we wanted incredibly robust mental health staffing at intake, where all of those screenings occur. We asked our medical providers and mental health providers to give us reentry navigators for folks that are reentering into the community. And one of the things I think that Franklin County is fairly well known for is our collaboration. We collaborate very well here in Franklin County. We have a very robust criminal justice planning board, as well as very robust community providers that we have very close contact with and deal with on a daily basis. And we wanted to ensure that whatever provider came in and was awarded our contract continue to maintain those relationships, because obviously we're looking to have that soft handoff from the jail into the community providers. Another big piece of our RFP was ensuring that not only were we doing medically managed withdrawal within our facilities very well, and again, in our new facility, we have a very robust pod that's designed specifically for those folks who are suffering from withdrawal. It is designed, it's an open bayed pod that has clear lines of sight everywhere, again, sized appropriately for security and medical and mental health staff to be embedded in the pods. The beds are closer to the floors. It has extra showers, extra toilets, things of that nature. It has a medical triage room built directly into the pod. It has an interview counseling room built directly into the pod. It has a classroom built directly into the pod. It has an area to begin medication assisted treatment and to begin to do some of those screenings built directly into the pod. So all of those things were important as we went through and talked about staffing the new facility with any of the potential vendors that we had. One of the things that we do here is we do collaborate pretty well, again, with some third-party vendors for our MAT program within the jail. So obviously you've got medically managed withdrawal and then medication assisted treatment, and we treat those as kind of two different things. Obviously, as a jail commander, and the biggest risk that we have is that medically managed withdrawal within our facility, but we also want to release folks back into our community in better shape than we got them. And by offering all three forms of medication assisted treatment is something that was very important, not only to the sheriff's office, but incredibly important to our commissioners, the funding sources, and all the folks that were involved in this process. One of the big things that we wanted was, and this is a tough thing to do in a lot of jails, was to not have to take our folks out of the facility to be able to offer those things. So ensuring that there was a way, especially for methadone, to be able to deliver that in-house instead of having to take folks off-site to do that. We also obviously wanted to be able to continue those folks who were on methadone in the community or were on Sublocade or Suboxone in the community, to be able to continue those in the facility. And quite frankly, what we were looking for is that the community standard of care was also there for our inmates. So we wanted to be able to do everything within the walls of our facility that they can do and initiate in the community, and we think we've done that. One of the kind of other interesting pieces to our current medical RFP. You have to remember, we're moving into a brand spanking new facility. This facility takes a lot of FF&E, or furniture, fixture, and equipment. And when you talk about FF&E, you think about kind of picking the jail up and turning it in upside down and shaking it. And anything that falls out is considered furniture, fixture, and equipment. We actually wrote into our RFP with our new medical provider that they were required to provide all of that furniture, fixtures, and equipment for all of the medical spaces in our facility. So that cost basically was deferred to our medical contract. And then our jails being built as a phased approach. One of our jails will remain open until the full completion of our facility. So we also wanted to make sure that they replaced or repaired any equipment in our current facilities. So all of those things were also pushed into our RFP. You heard Jim Martin talk pretty extensively about performance measures. That's something that we take pretty seriously here, and the performance measures that were embedded within our contract. Again, the main goal of these measures were to ensure that the community standard of care was there for our inmates, and that we were able to achieve NCCHC accreditation. Things like staffing penalties for positions that weren't filled, the quarterly audits where we look at basically 100 charts where 1 month we'll let, or one quarter we'll let them pick 100 charts. Our provider one quarter we will one of our contract monitors, or our clinical contract monitor, will pick the 100 charts, and we choose topics for those audits, and penalties, quite frankly, are based on a percentage of compliance with those. And CCHC accreditation, and for Ohio, it's ODRC, the Ohio Department of Rehabilitation and Corrections. Inspections are very important here, and there are penalties that are kind of based on deficiencies that come out of either of those audits or inspections. And then medication passes, there are penalties based on, I guess, med passes that are missed. There's a bunch of other ones in there, but I just wanted to give you an example of a couple. And one of the other things I think that I wanted to hit on real quick was that Risa talked about was data. We really we wanted to make sure that we obviously controlled the data. We worked with, quite frankly, when I started as the jail commander here, back before we did our first RFP, all of our medical records were still on paper, and we had no way to really use our data. And that was a big stumbling block, quite frankly, for Risa and the Dr. Osher and those folks who came in initially with the Stepping Up initiative to dive into our data, because everything was paper. We've obviously moved to an electronic medical record system, but you need to ensure that those records belong to you as the facility. And we've worked it out that basically I get provided a dashboard that it's pretty robust, and I can look through and look for those things that are being measured by the Stepping Up initiative as part of that data dashboard. So I think those are the highlights really of our current RFP. We could probably talk about this all day, and when we get into the questions and answers, I'll let kind of my team take over there. Captain Trowbridge is there, Stacy Williamson, who is our clinical contract monitor, and Janine Gillespie, who is our administrative contract monitor, in the room there with Captain Trowbridge in case folks have questions for them. Carrie, I'll kick it back to you.
No, thank you, Chief Stobart. And the one thing that I appreciate so much, Franklin County is always on the edge of being innovative. And I think, Chief Stobart, one of the things that, we heard was, sometimes we think we're doing, things are going well, and then sometimes we have to take a step back and kind of readjust. And I think with your new RFP, that was that chance to readjust. And what do you always say? Winning. I think that's always the term for Franklin County. And the way that we do that is by sharing, some of the things that went well and how can we get better. So I appreciate you, and Sheriff, thank you, Sheriff Baldwin, as always. We appreciate your leadership. So now let's turn it over to beautiful San Luis Obispo, who is not having a winter weather challenge. They're probably having more a sun issue, if anything. But I'd love to introduce you to Sheriff Ian Parkinson. Sheriff Ian Parkinson has been just an incredible partner with CSG in the Stepping Up initiative, and talking about some innovative and really creative programs. So Sheriff, thank you for being on with us today. And we'd love to hear about, your thoughts on medical contracting. And that can include obviously mental health as well, and some of the challenges and key takeaways for our listeners.
Great, thanks, Carrie. And by the way, Sheriff Baldwin, I do like the snow. Maybe not quite as bad as you are getting it right now, but a little bit more seasoned than California would be nice at times.
We will send you all we can.
Well, thank you and welcome to everybody for being on, participating. One thing that I know for sure is that these are beneficial because no matter if you're in Ohio, the East Coast or the West Coast, when you're implementing these issues or these changes, they have very similar problems. And so learning from other people and what they did is extremely important. Sheriff Baldwin mentioned earlier about the transition between custody staff and the medical staff. We experience the same issue. So I would first say that do not make a transition thinking that it's going to be the panacea of problem solving for you. You're going to have to pay a lot of attention to solving problems. You're going to have great staff, which I'm sure Sheriff Baldwin has, but I'll speak for my people, and I definitely have great staff that really stay on top of things and are constantly learning. This is an evolving process. I'll start and just say that the overview of stepping up is really important because that every single thing that was mentioned is key in being successful and continuing to be successful. I went through a presentation of stepping up just over 5 years ago, and we really believed in it. And as every day passes, you learn more and more about things that you can do. And I think it really starts with your contract provider for medical and mental health. When I took over almost 12 years ago as sheriff, I came from the outside, a 27 years at a police department before I took over here. So some of this was very new to me, and it seemed like the jail was the least of our worries structurally and how to move forward. But that quickly changed. So at the beginning, the county provided medical and mental health in the jail. And it was unusual because it wasn't just a regular contract that I had control over. The budget for jail medical was held at county admin or the public health agency. And we really didn't have control over what they did. And I didn't have the control to pull away from that staffing plan or that mode of providing this and go on my own and contract. And as time passed, I realized that what we were providing wasn't adequate and really was started to push for contracting, primarily because I saw other agencies that were contracting. They appeared to really have a handle on what unique circumstances it was to provide medical and mental health in the jail. What we learned along the way, as I said, it's ever evolving because we keep finding things that we want to do differently or better, and it seems like you're never satisfied with what you get. When we finally were given the green light to go out and contract, and we did that. The next step was really that transition of moving out really the county staff and moving in this new staff. It was unusual for us, all the employees. It was change, as we know, change is difficult. And what we found was there was a period of time of creating that change into a new provider, and that relationship between that provider and us, and how much time did we actually give them. Our goal obviously was from the beginning to get NCCHC accreditation. We think we're ideally, knock on wood, a couple months away from doing that. But there's a lot of things, that we found that we needed to do better. Mental health screening, and I know Jessica Yates, my business analyst, is going to talk about a little bit of those issues. But I'll say that what we found is that we had ideas coming from employees once they got on board with what stepping up was about, what the benefit was to the running of the facility by following those steps and rules. And ultimately, as stated, stepping up is about keeping people out of custody. Unfortunately, most of the time we become aware of them because they come in custody. So that transition coming out of custody is as important. And I think a couple have commented on that already, as when they're in custody and you're providing treatment. We had a new facility that opened just probably now 4 years ago, and we ended up repurposing half of that facility really into a mental health facility. And the purpose is that we had contracted with the state of California, state hospitals, to provide a jail bed competency treatment. I don't know if in other states the problem as bad as it is in California, quite frankly. There is an extremely long waiting list for people ordered to state hospitals. And what we were finding, they would sit for months in jail without treatment. And so we actually contracted for a treatment facility paid for by the state under the state hospital guidelines of how to provide it with our contractor, WellPath. And we saw incredible results, but also opening up a facility where I tell the story that I was very surprised that this idea was born. Hey, let's move a lot of these people that are severely mentally ill into this facility. And of course, the deputies are saying, well, this won't work because these people are 2 deputy moves. They can be really violent. This is really a bad idea. But they really sold me on the idea and said, we got to try something. We got to try something to improve rather than sit stagnant. And so the move happened on a Friday, and I expected my phone to ring Friday night, Saturday morning, Saturday night, Sunday morning, and it was crickets. I came in Monday morning, went into the jail about 6:30 in the morning and said, of course, how are things going? Did I not get a call there was a problem? And realized that there wasn't a problem and that things were going extremely well. And so again, the ideas were born by employees and connection with our partnership with our provider. We went to an incentive-based program in the jail where inmates that wash, take a shower, make their bed, cooperate with treatment, whatever that treatment is. They get credit points and are able to get things for free from the commissary. So we're encouraging positive behavior rather than disciplining for poor behavior. And this, particularly in this population, it's very difficult because they might not understand what poor behavior is, or they might not care, but they do care about, getting a candy bar or something else that they want or need. So it's worked out. And then the last I'll say to change on, because we're going to have obviously questions pending. Working with your new partner, you obviously control, and you have to be prepared to change your contract. We have amended our contract, and we will continue. We're getting ready to do another amendment that we've been working on. And you have to be prepared to do that, because I think what I noticed is a provider comes in and they know what you're paying already. It's public information. So if you're paying, $5 million for healthcare, and they're after the contract, they're going to give you the cheapest price possible while meeting the needs in their mind of the jail. And for me, what I have learned is that take the money off the table, focus on the care, number one, see what it actually costs. And I know that's difficult for some, but you ultimately you want to make sure that you are left with a partner that can actually provide it and is not cutting corners to do it. And so that's really going to take a deep dive in your RFP, how you present it, what you call for in your ultimate contract with them. And Don't just let them tell you, oh, we got this with this, this staffing level. Get deeper into it, because I think it's important. Otherwise, you're going to go back and make amendments because you're learning yourself. So I'll end at that, and then we'll get to the questions that come up later. So thank you.
Thank you, Sheriff Parkinson. I appreciate it. All right, so a couple questions. Jim, so looking from an NCCHC perspective, we heard a little bit, you were talking about discharge planning earlier. Why is this something that's so important to build into that jail medical contract at the very onset, making sure that it is a part of that conversation?
Yeah, great question. And it all comes from that, care as they're coming through the door and following them as they're being discharged. I try to look at the crystal ball and the tea leaves and figure out what are the sheriff's going to be dealing with over the next 5-10 years. Didn't see COVID coming, but what I continually to hear about from NSA conferences and other conferences that I go to and people I speak with is a lot of the progressive sheriffs who really want to be proactive, really want to try to affect their, the rate of recidivism, want to serve their communities, right? Want to be good partners, good stewards of the county, and good protectors of the people, is to try to help them after they get out, from whether it's veterans programs, getting them hooked into the VA, whether it's getting them housing, whether it's getting them connected to our community partners. Stepping up's been so important, having your mayor and your county commissioners and your judicial, your judges and your prosecutors and public defenders, all of them having a discussion about the mental health of the population, not just outside in the community, but in the facilities who come back out to the communities. All of our jail commanders on this presentation can tell you it's a revolving door many times. So, folks like Sheriff Parkinson is looking at providing services for the incarcerated after they've left his doors. That's a proactive thing that we should, continue to support, because it's going to affect who comes in next after them. That's in my opinion. That's what I saw working within our community. That's why discharge planning is so important, is getting them connected to the community services so you don't have to serve them again.
Thank you, Jim. Sheriff Parkinson, this is for you and or Jessica. So what's the most important thing you can do in working with your medical contractor, when we're talking about information sharing and data collection, to make sure that that's successful? Because that is one of the challenges, right? Is we're sharing information. What's one of the best takeaways on that?
I'm gonna let Jessie answer that question because she is so deep into this. I think she's better one to answer this question. Jess.
Hello. Yeah, I think actually the number one thing in information sharing is getting a shared definition as far as the basic requirements for that, because the reason is when we first started, if they defined severely mentally ill in one way and we defined it as another, we were never talking about the same people. And so our data was never good. So we actually started working with our behavioral health. We got a shared definition and we brought that to our medical contractor and said, okay, we're going by the DSM-5. Here's what we're going through. So we need you to define these people in that way. And then we worked with them to create a flag in their system so that each person that met that had that flag. And so it was very consistent. The other thing is you need to have that relationship with your medical contractor so that you can go in and audit that. Because if you don't have a discussion between them and you, there's going to be new staff. We've had new staff that comes in. It seems, we've, I think, gone through 7 mental health managers. Each one, we go in and make sure that they're on our same page so that the data that we're getting stays consistent and is the same, manager after manager, and then line staff after line staff understand exactly what we're looking for and why. Because if they don't see the bigger picture, then they're like, oh, they put SMI on there, even if it's psychosis from drugs. So you just got to make sure that you guys have an open communication, a shared definition, and that is countywide, and you keep training on it over and over. Don't just assume you set it up in the beginning of your contract and that they're going to continue to share that information within themselves. You have to be involved to make sure that they do that.
Sheriff Baldwin or Chief Stobart, one of the things you guys have been one of our leaders nationally as we talk about medication assisted treatment. But one of the challenges with COVID, because we didn't anticipate a COVID in that all of a sudden things would be so remote. So for example, telehealth became so very important, that ability, the ability to do a lot of remote telehealth, telemedical, whatever it might be. But Jeff, or Chief Stobart, you also talked about medically managed withdrawal, and you talk about, medication assisted treatment and all current 3 forms, whether it's, methadone, buprenorphine, or injectable naltrexone, whatever it might be. How do you anticipate and build into your RFP these things that are now things that we are directly dealing with, right? That we're aware of the need for more telehealth, the need for, to put in like all FDA approved, some things that we don't even know are that are cutting edge that are coming to us. How do you build that into the RFP so that when it comes to Sheriff Parkinson's point, you might get lowballed in the RFP, right? And anytime you want to add something, oh, that wasn't in the RFP. That's not in the contract. How can you build that in so that these safety nets and these very important conversations, treatment are built in for that which we haven't even quite thought about, or we haven't quite thought about expanding yet?
I mean, some of this goes into your contract negotiations after you've selected a vendor. And I'll be, perfectly honest with you. Here is something that we missed even in our second contract. One, needed to make sure that all 3 forms of medication assisted treatment are in the formulary with whatever provider you're going with. But one of the things that Franklin County was doing, or is still currently doing, but we're struggling with a bit, was we were providing Narcan for everyone at release. And we were getting some state funding to do that. That state funding has gone away. We no longer have that funding. We still have a significant amount of Narcan that we're still able to provide that. But that's not something that we actually built into our contract with our provider that, looking back on, we should have. So that goes back to what Sheriff Parkinson was talking about is, that's something that's probably going to require a contract modification at some point. That's a cost to the provider. You need to make sure that those things are thought about that you're wanting to do for your county. I'm going to kick it to Captain Trowbridge. Captain Trowbridge was heavily involved in obviously the medication assisted treatment part of this, as well as our contract monitors who are in the room. Carl, is there anything I missed on there? Anything you'd like to add?
I'm just going to add that between what the sheriff said and what a really smart attorney told me once, when you're going through this, words have meaning. So when you do look at something like this, you have to build in for future. So yeah, we want to cover all 3 now, but you have to build in for if there's something better that comes out, tip of the spear you want to try, you have to have that built in your contract, but you have to word that, because Jessica was right earlier when she said what they see as something and what we see as something might be 2 different definitions. So we got that right up front. So I believe that we are good for future endeavors, unless it's several years down the road, it might have to be a contract mod, but we have built in somewhat of a future forward looking with this.
Thank you, Chief. Thank you, Captain. Sheriff Parkinson, I would like to kick it back to you. If the medical contractor is not meeting the requirements of the contract, now the lawyer in me has a thought, but from a sheriff's perspective, how long do you wait to impose any type of liquidated damages? Is it better to wait? Is to hold them accountable from the beginning, or do you jump right in? Or how do you recommend? Because we're all dealing with, I shouldn't say that, but many of us across the United States are dealing with staffing shortages and some challenges, right? But this is a very real issue. Any thoughts or guidance on that from your perspective?
Well, it's interesting because we're having those discussions. I think you really, I think our approach is let's form this relationship. Let's get this partnership together. Let's not be in a situation where we are adversarial at the beginning. And you have to give an opportunity to for them to accomplish their contract. Certainly staffing is a issue, and if you have a provision written in there that they need to pay you when they have a position that's not filled, is challenging. But then you put on top of that liquidated damages. I think I guess my perspective is, hey, let's be friends, let's be business partners, and we'll give you a chance to be successful. When you've put the things in place or have things in the contract that you do not fulfill, then you have not only a right to collect damages, but also it kind of lets them know you mean business. So I would say that it really depends on how far off are they, and are they making every effort, and are they paying you, or are they working on meeting the contract as written. And so I think you got to be a little patient, because you got to give them a chance to succeed. And if you start dropping the hammer right away, you're really not building that team that you really need. You need that understanding. I mean, I think Jesse said it earlier with the verbiage, is that you have to be on the same page. And that means that it's business, and you're going to hold their feet to the fire if they're not succeeding, but you're going to give them a chance to succeed. So I think individually you have to make that decision when you're going to pull the trigger on that, and can give them some opportunity to perform. But at the same time, they're business too. They're there to make money, and they're there to provide a service, and they're obligated by the contract to do so. And if they didn't like that language, liquidated damages, then they should have fought putting it in your contract. So they're well aware that it's there, and that any time you can pull the trigger for their non-performance in those areas.
Thank you. And I think, your point is, it's about relationship building and working together. It's cross-training, security staff with the medical staff with security, because you are in it together. And at the end of the day, the sheriff has to provide that medical care. How you do it is absolutely within your purview as the sheriff, and to find that path that works best for you. Thank you.
And Carrie, I'll just add something based on what you said and what Sheriff Baldwin said earlier. How critical it is for your staff and that staff to work as one. They do have separate responsibilities, but the overall running of the facility requires both to be on the same page. And it really means that your custody staff has to realize, yes, this might not be their job, but letting the mental health staff do their job will make their job easier and more successful. And so it's convincing them of that, which is, it can be tough. And I can tell you, I lost some old employees, probably because they couldn't take the change, and they couldn't take what, where we were going. And so be it. It's time for change. And I think once you reach that stage where they realize the benefit of helping mental health do their job, is where you're really going to see the benefit.
And what I appreciate what you said is, our contractors are also, they're feeling that weight of it as well, with staffing shortages for our nurses, et cetera. And part of that too is having a conversation. What are some of the areas where even non-medical staff could assist with medical training, right? Are there some things that can be done with some medical assistance and oversight and training by medical staff? How can we get to a yes together? And then if we can't, then that's like a last resort. But I appreciate what you're saying. And I know we all have to be creative here, especially like I mentioned, understanding the shortages that we're all experiencing. So thank you for that. I want to come back to Jim Martin real quick. Jim, are there any resources out there for people if they're looking, kind of a checklist for RFPs, or some of the things that they can go to as they want to make sure they haven't missed anything, right? Especially some of the things we've talked about. How do you know you're not missing things that are, anticipated? And for example, one of my concerns always is when we talk about medication assisted treatment, you can put it in there, but sometimes we have providers who may not feel strongly about all three forms, right? So is there a checklist somewhere, or is there anything that where can our listeners in the sheriff's offices go to?
Yeah, thanks. We've helped some facilities in preparing their RFP and their contracts. Every time you think you have it figured out, then something else pops up, and you know, you're like, where did that come from? And you got to figure that out as well. You know, I know that we've, I would take advantage of your conferences, your state sheriff's associations, national sheriff's association. We've been a part of and seen RFP development type of seminars, and you know, they're out there electronically as well. Taking, you know, the advice of Chief Stobart, and I know that we worked with Captain Trowbridge before in some of the developments. There's no one perfect way of doing it. And if you've seen one RFP, you've seen one RFP, right? And you have to look around and see what's important for your staff. You know, I talk to people who are changing vendors, and they expect that, you know, the new vendor will come in with a busload of staff and just filter into your facilities. It just doesn't happen that way. So it's taking them through the same processes, and then look for the resources. You know, you filter.
Okay, thank you, Jim. I want to ask a quick question of Jessica, and then I would like to ask a question for Dr. Mark Stern. Jessica, do you and actually Chief Starbard as well, you both talked about data and the importance of data, and I absolutely applaud that. Do you audit the data and the information that you receive from medical contractor? And especially, do you audit that as you use it towards like your stepping up goals? You know, is there a connection there, and how do you do that? Jessica, let's start with you.
We definitely audit the data. And so I always say crap in, crap out. So if you're not starting with good data that you went and validated, then you're wasting your time building a dashboard. So we have in our contract built in read-only access, specifically saying we need read-only access for employees to do stepping up work and pulling that data from their electronic medical record. And we go in, I actually go in and I even look at the screenings where they said, you know, they did 90% of screenings. And I will, like they were saying earlier, I will go and audit and just pull up charts and see, did they mark the questions or did they not? So I do that quarterly. As far as the screenings go, we also audit their positives, and I'll go in and I'll print out a list of people who are positive, and I'll sit with the mental health manager and verify, does this person have the definition of our shared definition SMI? And sometimes they don't. They have new staff who just mark the button, or sometimes they take it off on accident. So you definitely need to screen that, because we take that information from the EMR, we merge it with our CGIS information, and then we put out a dashboard for our board of supervisors, for the sheriff, and for everybody else who's involved in stepping up. And so we need to make sure that we have correct data, so that we're putting the resources where they're needed, and making sure that we can watch that population, so that, you know, we're not getting ahead of it, but we have real-time numbers that are true.
Thank you. Chief Stobart, anything on the data piece of it?
Yeah, I mean, obviously things are a little bit different here in Franklin County. You know, when I talked about collaboration, we actually have an Office of Justice Programs and Policy that falls underneath our county commissioners. So all of the data, all of the metrics that fall under tracking, all of the things associated with the Stepping Up initiative actually run through that office. But everything that Jessica said is exactly what they do. It's the exact same stuff, all of the same metrics, all of the same things that Jessica is talking about are things that our Office of Justice Programs are the things that they're tracking, they're paying attention to, and processing. Carl, is there anything from, you know, as far as our contract monitors that you'd like to add to that?
Other than the dashboard being built right now, Chief, of how we're improving it, I don't think so. So our vendor has a dashboard. It's got a lot of metrics on it. We get stuff out of it, but there's like 5 or 6 things that they're improving. Well, we're making them better because of what we want to see. And I'm sure there's other people around the country that want to see that they're building that metric. So we are customizing the dashboard to us, which is one of the things that's in our contract of the things we want to see. They'll build it for us. So there's going to be 8, 10, or 12, depending on what you want to see on your dashboard, that you can look up every day in real time.
Excellent, thank you. And I'd now like to turn it over to Dr. Mark Stern. For those of you who don't know Dr. Mark Stern, he is a physician. He works in Washington State. He's also the chief medical advisor to the National Sheriff's Association. Dr. Stern, you've worked with jails throughout the United States, and especially during the pandemic. We thank you for all of your help and your guidance and assistance. Any recommendations from you, suggestions, takeaways that can help all of our listeners today in the
Sure.
area of medical contracting? Thank you.
Thanks, Carrie. Just do a sound check first because I had some trouble getting on you. Good, very good, excellent. Some thoughts. One overarching thought, and I use this analogy of a submarine captain who isn't expected to be a nuclear physicist, but if they have a nuclear submarine, they better understand enough about nuclear stuff so that when they're walking through the engine room, they know when it's overheating or there's gamma rays escaping or whatever. And so I think the analogy to the jail commander is you can't just contract for healthcare and say, now I can go on and look at food service. You have to remain involved. You have to keep your eye on what's going on, just like that captain walking through the engine room. There was a question in the chat about money, and I think, so just to move on to another point, how do you not get lowballed? One of the challenges of getting good healthcare in our jails is paying enough. And I know that, I know all the challenges that go with that. I know the county commissioners and those challenges, but you get what you pay for at the end of the day. And when you contract, you get a little bit less because there's a profit margin. If you do it generally, I mean, there's other places where there's going to be differences. So it's really helpful to look at what is the cost of care in your community. For example, look at Medicaid. If you have, because most of our patients, when they get out, they're going to be Medicaid type patients. And if what Medicaid is paying for healthcare for the types of people you have in jail is a lot more than what your contract is for, then you have a gap. And you could have the best contractor in the world, you could have all the systems in the world, but you're not going to get the work done if you're not paying for it. Jessica made a really good point about information. That is also helpful in the cost of getting the right cost of the contract, which is it's really helpful to contractors if they get as much detailed information about your operation during the RFP process, the RFA process, whatever you call it. I think a lot of jails I've seen are stingy, not to be mean, but they just say, well, we've got a jail, here's our population, here's how many beds we have. The more detail you can give them, and Jessica was getting into that, about DSM-5 classifications. How many people do I have who've been on suicide watch? How long were they on suicide watch? How many people are taking antipsychotics? How many psychiatrist appointments are there? How many times have I had to send somebody to the state hospital for competency evaluation? How many people are self-harming, and how many days? Those kinds of level of detail. Then you have a contractor who can look at it and make a reasonable estimate, assuming they're being honest, which we want to assume, much more than just saying, we've got 50 people who are SMI. So the more rich information you can give, the more helpful. Can I keep going, Carrie, or?
Yes, go ahead. One more really good point.
All right. When you write the RFP and the contract, you want to have variables that you can measure, and we've talked about some of those. What the biggest problem is that we tend to focus on variables that are easy to measure. They're counts. Was this done? Was a screening done, or was something done on time? And I think we have to have, in addition to those, quality variables. Not only was it done, but was it done properly? Was it done well? And those are harder to measure, which is one of the reasons that we tend to stay away from them. But they're very, very important for being sure that people are not just doing it, but they're doing it correctly. So I'll stop there, Carrie. You're on mute.
I was so good this whole time. Thank you. And I really appreciated those comments. It's so true. The goal of all of us, whether as the sheriff, as the provider, as all of the staff, is we're all trying to improve health outcomes and help individual, not only so when they leave in a better place, and it helps to improve their health outcomes upon reentry, and to try to, remove any gaps in care. So I appreciate the conversation and I appreciate all of the advice that you've given us thus far. Reese, I'm going to turn it back to you because I know there's some questions from all the rest of the attendees today. So back to you.
Thank you so much. And I just found myself, really appreciating, I think, all the candor today. I feel like some of these discussions have been kept to the back room and, are just, you learned it on your own in your own county. And, just to kind of have a really open discussion so that we can all learn from each other. I know we heard, if you've seen one RFP, you've seen one RFP, but I mean, I think that there is still, some basics, and certainly in our work through Stepping Up, that's what brought us to this, is just like how important that relationship is if you're particularly looking at an outside vendor coming in. And I know I appreciated one of the questions in the chat about not alienating your contractor. And I know that, I think it was Sheriff Parkinson said, you want to start off with some trust and on a good foot here. And, I think, what we heard, that how important that is, along with, also the same message, you got to keep your eye on the ball, and you can't just assume, as it was so wisely put, you can't just say, okay, now I'm moving on, to the next, jail related, administrative responsibility. Just another one I wanted to bring up to either of our sheriffs or anyone is, it was in the chat about, it feels like we're forgetting to address trauma, and that might not rise to a full diagnosis, or to the full level of what it feels like we've been pushing with the Stepping Up and the definitions. So I don't know if either one of the jails want to talk about, if you're feeling like you work to achieve a trauma-informed staff and facility, and how you address that. So I don't know, Jesse, I see you shaking your head. You want to take it?
No, I'll just mention that through the Stepping Up, we were actually able to send some of our jail staff through Train the Trainer for trauma-informed care about 1.5 years ago, which was great. So we have, sergeants and senior deputies who've been trained to actually train each other on that as well. So we definitely do look at that trauma, as a lot of people are in the jail because of, adverse childhood experiences. And so ignoring that would be adverse to really what our goals are. So that is something that here in San Luis Obispo, we do work into training our staff for that as well.
And go ahead.
I just add on one thing to what Jesse said, is that it goes back to the fundamental issue of getting your staff to understand the direction from the top, what the expectation is. And yes, there's a lot of training out there. We do a 40-hour CIT course that is all deputies have to go through, custody and patrol. But I think it's that mindset of changing and understanding that, identifying those issues and addressing those issues with the proper people will make their job easier, and really will. And it is part of their job. It's not something they're doing that's not part of their job anymore.
Thank you, Sheriff. I was going to turn it over to Mark. I know he has some data related questions from the chat and some information from Stepping Up on data. Mark, I don't see you. You might be on mute.
Oh yeah, sorry, I was just taking myself off. But yeah, and in the chat, there was a question about sharing electronic health records, but also retention of that data as well. And I wasn't sure if either maybe the Franklin County folks, if you want to go first, or then the SLO folks, if you have anything to add.
Carl, do you want to take that?
He faded in and out on our end, Chief, so I didn't get the question, or I can.
Yeah, sorry. It was the question about sharing electronic health record information, and also retention or ownership of that data as well. Like, how do you navigate that in the contract?
So from our last vendor to the new vendor, we moved all records, even all the historical records, which we got a little pushback, but it was in the RFP that all medical records will be transferred to the new one. They wanted to not argue. They wanted to have a discussion that anything longer than 6 months is not really relevant, which to my argument is, well, then my doctor should throw away my whole medical record after 6 months, which I don't agree with. So it all is very good information, especially if you're a long time recidivist that keeps coming to the door. All that information is great. So, and we made sure that they knew that all medical records are our property of the Franklin County Sheriff's Office, and how we share them, it depends on who we're sharing them with. Mostly is through a ROI, but we do have some BAAs, business associate agreement, to be able to share it. And we're currently in the process of getting in. So there's 5 major medical hospital organizations in Franklin County. We're trying to get, they have a hub where they all share all their information between the hospitals. We're trying to get involved in that, so they will share ours and we would get theirs. So access to their EHR on top of ours.
If I can just add one point to Carl's comment, there is also not only the issue of the legal ownership of the record, but there's also a cost that can be involved. If you're going from one vendor to another who has a different electronic health record, there can be a translation cost to write code to move it from one to the other. And you need to anticipate that in the contract. I suppose you could put it at the front end or the back end. In other words, the current contractor has to pay for the cost of moving that data to the other one, or vice versa. The new contractor has to pay for importing it, but there can be a monetary cost to that.
Dr. Stern, there was a cost. If I jump in real quick, there was a cost, but we put it on the new vendor to retrieve all the medical record from the old vendor, but they knew that up front, and that was built into their pricing, is all the medical records must come to us. So however you need to make that happen, whatever the API needs built, so be it, but they all are coming.
And then Sheriff Parkinson or Jesse, do you have anything to add on top of that from your experience?
Jesse?
As far as ownership goes, I think that's huge. We did write in there that in our contract, it says that we do own all of the information. And we also put in there that at their cost, they are to make sure that they're compatible with our current systems. And so they need to work with us to make sure that we can share the information back and forth, which I think is something important to think about as far as that goes. But if you don't own the data, I think that would be a big problem with your RFP. You definitely need to put in there that you own the data.
Great, thank you. And then Carrie, do you want to cover the Medicare, Medicaid question that came up in the chat?
I'd be happy to. Real quick, just real briefly, the question had to do with, especially for our pretrial population, who is very quickly moving in and out of our facilities. Just something to keep in the back of your minds, and for those of you who are tracking it. So the federal Medicaid inmate exclusion policy, as you know, prohibits the receipt of federal benefits, Medicaid, Medicare, CHIPS benefits for incarcerated individuals unless they go to the hospital for more than 24 hours. One of the National Sheriff's Association, working with NACO, the National Association of Counties, also a Stepping Up partner, and now Major County Sheriffs of America, working together. There is a task force to help address some of those health inequities of the Medicaid inmate exclusion policy. One of the things that I would encourage you to look at, because there are many pieces of legislation, this is a bipartisan issue, trying to make federal benefits available for the inmates 30 days prior to release, if not longer. Several states are right now have Medicaid waivers that are going up to try to see if they can get those. But more than anything, think about when you build into your contract, because if in fact there is some changes to the legislation where in fact we are allowed to actually bill for Medicaid or Medicare during the time that these individuals are with us, those eligible individuals, you're going to want that built into your contract, right? So that they are eligible then, or they can then bill Medicaid, Medicare, depending upon your state. And depending upon if you're a suspension state, I would build in. And again, whether it's their medical staff or if it's your staff, we want to make sure eligible people coming in. Remember, reentry begins on the day somebody comes to you in a jail, right? So we want to make sure that if they are eligible, right, that even if they're suspended, that we catch that before they leave as best we can to get that, to get their benefits clicked back on. And then for those who are eligible but are not enrolled, we can help to start that process. But those are things you just might want to be thinking about in your RFP. What's the impact of the federal Medicaid inmate exclusion policy? What happens if we get legislation that potentially allows you now to bill and cover some of those costs? So again, things on the horizon that may not be here, or they might be, but how do you build that into your RFP? So again, we can help to fill those gaps for individuals who leave, so they can get coverage, so they can get to their appointments, get their medications, et cetera.
Thank you, Carrie. I'm just want to jump in as we're closing down on our time because I noticed in our chat, so it's perfect segue that this discussion needs to continue and we need to have more opportunities for learning and sharing on this topic. And for that, I want to call on Reggie Herder from PRA, and she has some exciting news from their agency.
So hello, everybody. Wonderful conversation. And I appreciate the opportunity to be on here. This is a big area of interest for us to really be looking at kind of that checklist, that question earlier about, is there a checklist? Is there kind of a cheat sheet of what to look at? And in all of my looking at all across these different systems, there really isn't that checklist right now. And so that is something that we are taking on. And so there's folks on here know that I will be reaching out to you for your wisdom, but also just really putting together what does that checklist look like, both around an RFP as well as for contracts. And I just want to reiterate the importance of mental health, but also the work we'll be talking about is mental health substance use, but also IDD and acquired brain injury, and then co-occurring, because we're also seeing, and also other disabilities, hearing being a big one in facilities, that there's a lot of interaction between all those different factors, and that oftentimes we're putting out RFPs that might focus just on primary care or mental health, but not really integrating all of that. And then also, I think something that this group has not necessarily focused on is that what I often see in different jails is that they have more than one provider. So they might have a medical provider that's a primary provider, but they have somebody else that's doing mental health, and that those groups are not talking with each other. They're not collaborating with each other. And so those are proprietary kind of transactional systems. So all that to say, and I'll put into the chat my contact information. If anybody who is out there listening to this is interested, please contact me. I'd love to talk with you about your lessons learned, about what your RFPs are saying, and reading those and looking at some of those best practices. So both RFPs and contracts, really looking at some of your place-based strategies as well as your person-based strategies, hiring, leases of information, all those different kinds of practices. So thank you all for the great work that you all are doing. I come from Denver, Colorado, that has a pretty strong basis for providing services. So I've been fortunate with that. And again, our goal is to simply try to get out more information and to start kind of creating that boilerplate. So thank you.
Thanks, Reggie. And I know we're coming up on time, but we wanted to give a very big thank you to our panelists today for your presentations and for the great discussion today. And thank you to all of you, the attendees, for listening in. This slide has the panelists' contact information. I know that there were some questions that we didn't get to, but the panelists would be happy to follow up with you one-on-one. And again, this webinar was recorded, and we should have the recording available on the Justice Center's website by early next week. So thanks so much again, everyone, and have a great afternoon.
Thank you.